now the director of our catheter laboratories, where a lot of patients come for their cardiac interventions. And I'm heavily involved in cardiac research. It's one of my passions, and I do a lot of leading on clinical trials, which will help hopefully determine future treatment plans for people as we iterate new technologies and so on and so forth. With that, that gives me the great opportunity to teach junior doctors at the same time. And in my 10 years, every 2 years, I've run an MD for trainees, and I've managed to get 4 through so far, and another one later this month, hopefully. So that's good. With that, also, I'm part of the acute myocardial infarction 24/7 program. So if you have a heart attack in Brighton, or indeed any of the surrounding area, you're brought to the Sussex Cardiac Centre, where we will offer you treatment of your heart attack 24/7. I do 2 full lab days per week on a Monday and a Wednesday, and I have 2 clinics to see patients at the same time. So that's me. Anyway, moving on, my presentation is about miniaturization in medicine. And I'd like to say that some people would say that bigger is better. Indeed, some might even say that bigger is always better, but I would disagree. I would suggest there's not much in life which is bigger better. And certainly when it comes to medicine, I feel that smaller is definitely better. And let me offer you some examples. Doctors' hands, definitely, if you're going to have a prostate examination, are probably better smaller than bigger. Size 6 gloves are definitely going to be better than size 8 gloves. Similarly, if you're going to have a thermometer put in somewhere, or indeed a catheter, smaller is always going to be better. I jest, but over the last few decades, medicine has been constantly trying to downsize. And the reason for that is open surgery generally involves a longer length of stay than things such as interventional procedures. It improves patient care, it returns people to quality of life much quicker, and it's more cost effective. And we all know health economics are a big issue. The average night in hospital is more expensive than any hotel in London. If you take an average costing of a standard hospital bed, it's around £750 per night. And so length of stay is really critical to health economics. There has also been huge investment by industry to try and support miniaturization in medicine, and that's because the global medical device market, it doesn't matter not just in cardiology, but in renal medicine or respiratory medicine or other forms of surgery, is worth a huge amount of money, around about 512 billion last year, and it's projected to grow to nearly 800 billion by 2030. So this whole idea of a more procedurally based medicine where we are less invasive is really taking off at the same time. So let's bear in mind that while medicine is very old, surgery as a treatment is actually very new. And indeed, the first coronary artery bypass operation to treat people with narrowed heart arteries was only done in 1960, and that was done in the USA. Surgeons were the forefathers of miniaturization, and probably one of the best examples for that is the idea of laparoscopic surgery, which some of you may have actually been or had. Laparoscopic surgery was only invented in early 1980 by a German who performed the first laparoscopic removal of an appendix. And he presented his research at a meeting at the German Surgical Society, where at the time, the president of that society thought it was so ridiculous that he tried to get them suspended as a physician for trying to treat people this way. But there's no doubt minimally invasive surgery had advantages. There was quicker healing, shorter lengths of stay, which I've mentioned, and a lower risk of infection, albeit at the slight disadvantage of a slightly difficult learning curve initially, and the fact that if there was a complication, you would have to retort to an open procedure. But if we move on from there, only one further step. What if we could use the body's own conduits to deliver therapy? So what about the arteries and the veins, which we know run all around our body? And when we started to think about this, this was the birth of catheter-based intervention. This was so in 1977 came the birth of modern day cardiology at that point. And prior to that, if you had bad chest pain, for example, what we call angina, which is an exertionally related chest tightness, at that time, you could either wait for a coronary artery bypass operation. The rough waiting times around there were between 18 months to 2 years, or you died because you just didn't get through to that surgery at that particular time. And as the cartoon shows down here, what they would do would sew either an artery or a vein round the narrowing so that blood flow would preferentially pass down past the narrowing and relieve the angina, which was occurring when people were exerting themselves. But as you can see from the picture on the right, opening your chest is a major undertaking. Then in 1977, Andreas Roland Grunzig came along as a German cardiologist who presented at an American meeting a wacky idea about using a balloon to open up a narrowed segment within the artery. He dilated a short 3mm section of the left anterior descending artery, which is the main heart artery, which supplies 60% of the blood flow to the heart, and the patient survived. And this is the original angiogram, just where the little red marker is, and where the ring is, you can see the black line of normal artery here, and then further down in this critical narrowing, just where the marker is, and then you can see the result here from him undertaking the balloon angioplasty. And this was the birth of percutaneous coronary intervention, the ability to use the body's own conduits to treat within the heart. And it started off being done through the femoral artery at the top of the leg. And that's how I was taught right at the beginning. Let's look at sizes just to put these all in perspective for you, all right? The size of catheters that we use nowadays relate to what's called the French scale, which looks at the external diameter. And they all started off, these catheter-based interventions, at about 8 to 10 French, which if we look on the graph here, is between 4 and 3.7 millimeters. But most coronary work now is done through 5 to 6 millimeters catheters, which if we look down here is more like 2 millimeters in size. And more importantly, we've moved to the radial artery on the side here, because if there is any bleeding, we see that as a little eggshell or bruise, whereas you can bleed quite a large amount into the leg without necessarily detecting it. And with this came the advent, after just the balloon technology, of stents. And stents were the ability to crimp a small metal mesh down onto the balloon with the ability to prevent recoil of the artery. So when you blow up a balloon in the artery, the narrowing generally expands, but sometimes because of the elastic nature of arteries, they can recoil back down. And what we wanted to do was try and prevent this to get a more durable and long-term result. And stents offered the ability to scaffold the artery open and prevent this recoiling from happening. They started off as what we call bare metal stents, so just made of metals such as cobalt chromium. But slowly they started to realize that if you covered these stents with chemotherapeutic agents such as sirolimus or paclitaxel, which are used to treat quite a lot of cancers nowadays, these were indeed anti-proliferative and prevented further narrowings forming in the stented segment. And here you can see the cartoon. You can see the catheter coming down through the narrowing, and here you can see what is an atherosclerotic plaque. And in the cross-section here, you can see that this has narrowed the artery and the lumen of the artery quite significantly. The stent is then expanded into position, and that widens the artery so blood flow can become normal again. And again, you can see this nicely in this cross section here. Here's a case that I did recently. This was a 47-year-old gentleman. Like a lot of the time, he went to bed telling his wife that everything would be all right in the morning. Don't worry, love, I'm going to take 2 paracetamol. I'll be right as rain in the morning. And at 2 a.m., we got called because he was getting bad chest pain. His wife called an ambulance, and at the point of first medical contact, an ECG was done, which revealed some ST elevation, which is the hallmark of acute myocardial infarction. He came to the cath lab in Brighton, and as you can see here, we were able then to see this critical narrowing. Let me just show you with the cursor here, just in the middle of his artery here. And you can see blood struggling to get down through the rest of the artery. So you can see a sort of 3 or 4 millimeter artery at the beginning here, another 3 or 4 millimeter artery further down, and in this middle, a very tapered and narrowed segment, which was compromising the blood flow. So we put a wire down through this narrowed segment. We then put, after some ballooning, the stent down into the right position. We then expand the stent into the artery, and you can see that this mechanically stores a flow in this middle picture. We then optimize the stent with another balloon to make sure that the bigger part at the top is blown right up against the wall of the artery, and then you'll see here the final result, which restored the flow mechanically back into the artery, back into the heart, aborting the heart attack at that particular time. And if you have a heart attack anywhere in the UK, pretty much most of anywhere in Europe now, this is offered 24/7, 365 days a year as your treatment of choice, because unlike the liver, the heart doesn't regenerate. Therefore, any damage done to your heart muscle is a long-term issue. And we all know that if you damage your heart significantly, you're going to run into problems with symptoms of breathlessness ongoing as you become older. And actually, there can be a number of long-term sequelae, such as palpitations, which can be dangerous, or indeed long-term conditions such as heart failure. So this is where we're heading now. Could we scaffold the artery, but actually only temporarily? We know these arteries are elastic. We know they recoil. But if we could avoid leaving a metal body in the artery, so much the better, because any kind of foreign body left in an artery is not ideal. The risk from it is incredibly small, less than 1% per year. But if we don't need that 1% risk at all, maybe it would be even better just to scaffold the artery temporarily. And so the hypothesis of where research is going in this area is, could we scaffold the artery maybe for a period of time, say up to a year, but then that scaffold dissolve, leaving normal vessel architecture, normal vasomotor function, and all the important parts of an artery into the longer term. And this is the birth of things such as bioabsorbable scaffolds. And these are made, unlike a metal stent, of something called polylactide, which essentially then dissolves by degradation over an 18-month period into water and carbon dioxide, which is absorbed by the body and got rid of. And you can see on this image of the artery from the inside, the scaffold here in cross-section up against the artery. 6 months, it's already starting to resolve. At some points, you can see here from 9 o'clock round to 3 o'clock, no more scaffolding, but you can see some scaffold between sort of 8 and 6 o'clock. But at 12 months, no scaffolding and pretty much normal architecture of the vessel at that particular point. So this is one area where we're concentrating a lot of research to see whether this will have a long-term benefit. Similarly, we've come pretty much full circle now to the idea of what about if we just use balloons to open up narrowings, but instead of having a stent on them with a drug on top of that, we just use the balloon with a drug coating on the top. And maybe the drug alone is enough to prevent recoil of the artery at the same time. Again, the benefit of not having to leave a foreign body in you long term, the ability therefore that you may not need to take longer term medicines, for example, aspirin or its sister drug clopidogrel, which if you're elderly does increase the risk of you bleeding a little bit at the same time. But obviously everything in medicine is a risk benefit. Clearly having a heart attack puts you at risk of dying. Therefore, even if you have to have a stent, you're going to take that risk at that time for the prognostic value of saving your life versus the risk of bleeding from the aspirin or its sister drug clopidogrel. But this, you can see, is where we're heading, always trying to minimize, cut down on the amount of material left in the body, cut down and minimize the amount of medicines that we need to leave you on, always trying to improve your overall risk overall. What about intracoronary imaging? This is again another area where we were not content with being able to deliver micro treatments. We needed tools then to critique our treatment. And we now have the ability to get spatial resolution similar to that of a CT scan within the heart arteries. The CT scan was first designed back in 1971 and offered non-invasive imaging of organs and any conditions associated with them. It revolutionized the treatment or diagnosis of cancer. And indeed, this was developed in Atkinson Morley in Wimbledon in England. And Sir Godfrey Hounsfield, who was the forefather of CT, won the Nobel Prize for Medicine for coming up with this. We now have this in the ability to look at arteries at the same resolution of a CT scan. So we can put this down through a 6 French catheter, which was roughly around about 2 millimeters. And you can see here in cross section, this is what the catheter looks like. And here's a live video showing a pullback through the artery, which enables us to see that it's significantly narrowed along its course and where the disease may be. So not only does it tell us where we need to treat, it tells us the length of the treatment option at the same time. So we can put the correct length stent in. And then when we've put the stent in, we can see, have we done it well enough? Because what we want you to have is a long and durable result from any intervention. Here's a case where now, due to the resolution, this is a plaque rupture. This here is a lipid-rich core and it's lipid-rich cores that rupture open, which cause heart attack. And we can now detect those in your arteries. Similarly, here's a stent that you can just see the metal frame going round. But if we want it to be durable, i.e. last a long time, we want this stent frame to be pushed up, right up against the wall of the artery. And you can see here from about 2 o'clock round to 6 o'clock, there is an area which is malapposed. And so intracoronary imaging would tell me that I needed to put a bigger balloon in to expand that into position further. What about if people stop taking their medication? Sometimes they can get narrowing within a stented segment, and this is what we call stent restenosis. And you can see here that all of this tissue from 1 o'clock round to 6 o'clock is where some restenotic tissue has formed, and now we can put those drug-coated balloons in, put the drug into this tissue and dissolve that back down to make a more durable result with the stent again, without having to put a second stent, a second layer into that area. Similarly, it gives us quite remarkable 3D pictures where we can, for example, see where a side branch is and our wires down through the side branch to guide where we need to be. So this would be going from 3 o'clock to 9 o'clock, the main wire in the vessel, and this is one here just above it, which is going into a side branch. But we can see the excellent scaffolding of the stent right up against the wall of the artery, which is what we want. What else? Well, actually, calcium is the interventional cardiologist's nemesis. It's the Joker to Batman. It's the Scaramanga to James Bond. Essentially, as we become older, plaques, which start off as they are as fibrofatty, start to become calcified, a bit like a copper pipe in the kitchen, and they slowly start to obstruct the blood flow. And calcium is very, very hard to treat. So we now have two new technologies that enable us to treat them. A bit like a dentist drill, we have what's called rotational atherectomy. So a diamond encrusted drill that will drill out an artery for you. And even if we can drill out only so far, we now have something called intravascular lithotripsy, which is the ability to put a balloon into the narrowed segment and offer ultrasound sonic booms into the calcium to disrupt them and get a good result. Here you can see a near circumferential crescent of calcium, which is this light area behind the artery, again shown by the OCT imaging I showed you earlier. And this is pretty much going from 6:30, 7 o'clock, all the way around the artery to 3 o'clock. And you can see here at 12 o'clock, similarly at 6 o'clock, where post the intravascular lithotripsy, it's broken the calcium, which means that when we put the stent in, our luminal area suddenly gets a lot bigger and more blood flow can come down. This technology all came from the treatment of kidney stones, which some of you may have had, where if you bombard them with sound waves, you can disrupt the calcium which makes up these sorts of things. So really interesting that this is where we are with our coronary work as it stands at this stage. Moving on, well, we all know that we have an aging population. People are living longer and longer, and 70 is now the new 60, 80 is the new 70. Excuse me, and people favour quality of life irrespective of age now. They still want to be able to do everything that they did when they were in their 40s and 50s. And so we are seeing, as medics, a tsunami of diseases which were not previously seen because people didn't live long enough to get them. And one common thing is a disease process called aortic stenosis, which is narrowing of the main exit valve of the heart. If you look here to the right-hand side, this is the most contemporary WHO statistics that I could find. And if you look at the aging population, by 2030, or if it's 2030 or 2050, we are going to have a population of nearly 9 billion, of which the vast majority of them, you will see in the black bars, the growth of the population over the age of 65. So valve disease is going to become commoner and commoner because of it not being due to infections such as rheumatic fever that used to be the primary cause. It's now all related to an age-related degeneration. And that's because the leaflets of your valves have been opening for every second of every minute of every day for the best part of 65 plus years. And so much like your knee might be arthritic, your heart valves start to become arthritic. And this can cause to either leaks or narrowings and symptoms such as breathlessness. And before about 12 years ago, the only treatment for this was open heart surgery, where the surgeon would again open your chest, much like the bypass operation. They would cut out the old valve and they would sew in a new one made up of a metal frame or metal valve completely, or indeed a plastic frame sewn within it leaflets from what we call bovine, so cow or pig pericardium. And that would be the treatment of choice. What they found in around about 2013 was that despite there being all these people who had heart valvular disease, which was causing symptoms, about 25%, so a quarter of them, couldn't undergo surgical treatment because they had other comorbidities, for example, bad diabetes, bad kidney function, or indeed maybe had a previous stroke. And when they didn't treat these patients, the only treatment was tablets or death. And again, if you leave aortic stenosis untreated, there is this latent period where you do okay, but once you develop angina or heart failure or indeed dizzy episodes, you suddenly fall off the cliff, and your risk of death at that particular point is roughly a median of around about 2 to 2.5 years left untreated. And this led to the birth of transcatheter heart valve replacement. What, again, if we could use the body's own conduits to deliver treatment. This time not a small stent, but this time a whole heart valve replacement. And this was done by a pioneering French cardiologist, in fact only died earlier this year, Professor Alain Cribier, who was working in Rouen in France, where he managed to implant a fully percutaneous keyhole heart valve replacement. Now, TAVI, that some of you may be aware of, is a treatment of the aortic valve. And often that's down to, as I said, senile degeneration of the valve as one gets older. It's done from the femoral artery. It's done 18 to 24 French, so about 7 millimeters in size. And the valve is crimped down onto a catheter, as you can see here, and the catheter is inserted through that artery and brought all the way up to the aortic valve and either expanded into position because the metal is self-expanded, or ballooned into position at the same time. And actually, when we do this, it relieves symptoms remarkably well. It reduces length of stay. People are in hospital for maybe 24 to 48 hours. And most importantly, it prevents your chest opening, which saves you the recovery time of 3 to 6 months until you're back to your fighting weight. Remember, your chest is a bone. Once that bone is broken, if you broke your hip or your knee, for example, that's 3 to 6 months. It's the same with your chest at the same time. And here's two of the very typical TAVI valves that we expand in Brighton. This is the Edwards valve from Edward Life Sciences, which is ballooned into position. And this is the core valve, which comes from a company called Medtronic, which is made of an incredibly clever metal called nitinol. And for all the engineers out there, this is a metal which, once you put it in cold water, contracts down. But that's once you put it into the body temperature, into blood at a temperature of 37.5, it's constantly trying to expand to hold itself in position. So here's an example of the self-expanding TAVI. We come across here the aortic valve, so your heart, let's get my pointer, would be sitting around here like so. All right, this is your aortic valve just across here, and so we bring the catheter down over the aortic valve, and then we retract essentially a sleeve backwards like this. Sorry, I'm trying to do it. And then that enables you to see that the valve then slowly comes out into position, and it comes out like a crocus, and then sewn within the metal frame are new leaflets which take over the function of the old one. And unlike the surgeon, we don't even cut out the old ones that you have there. We leave them pushed into the sinuses on the side. We now have second generation valves. For example, this one here is where, again, there is narrowing of the valve just across here. We put in a big balloon to open up that narrowed segment, and then the valve is held. But this time the valve's repositionable, so it's not one shot. If we get it wrong, we can roll it back in and we can put it in the correct position next time round. And that's made a big difference to the risk of complications and so on associated with transcatheter treatment. And again, you can see here the valve is being pushed down a bit like a slinky, one of the old toys which you put down the stairs. Again, you can see it's now starting to take its shape here into the aortic valve. And then once it's released, it's taken over the function, and the blood's all going in the right direction again with relief of symptoms. So TAVI has become a critical treatment for aortic valve disease, and indeed in most European countries, including our own now, most aortic valve disease is treated by transcatheter or minimalistic treatment, all keyhole, all through the artery at the top of the leg, rather than open heart surgery. The advantage is it avoids general anaesthetic, again, something which is not that well tolerated in an elderly population. The recovery time is very quick. As I said, generally a 48-hour admission at the same time. And even if we can't do it through the leg, sometimes we can do it through the artery in the arm, or indeed through the vein crossing through into the main aorta. Now, like everything in life, it doesn't come for free. There is a 3% risk of major complication, 3 in 100. Surgery is probably a little bit higher than that in this age group. And remember, 25% of people wouldn't even get an operation because they've got other medical problems. But probably the most feared complication is that of stroke. People probably, pragmatically, aren't too concerned if they die from a procedure, but they are upset if they're maimed by a procedure. And stroke doesn't kill you, stroke maims you. It takes someone who was otherwise completely independent and leaves them with weakness down one side of their body, difficulty eating, all these other bits and pieces. And the stroke rate associated with TAVI is somewhere in the region of about 3%. But the UK as a whole is leading on a clinical trial of nearly 7,500 patients, where we're looking about whether two nets in the brain are useful in terms of catching debris as the valve is expanded into position, because obviously the valve is made of the narrowed valve is calcified, and can we catch some of this micro debris to prevent it traveling north to the brain and preventing stroke? And this clinical trial, we've recruited around about 6,000 patients and is due to report sometime next year. There'll then be 1 year of follow-up. And if this reports positively towards the nets, then it will push commissioners to have to recommend it as standard of care for the treatment of aortic valve disease via transcatheter heart valve treatment. What about other heart valves? Well, actually, we are trying to get keyhole technologies into other valves, particularly the mitral. The mitral is, however, a much more complex valve. The aortic valve is only a pressure valve. So as the heart contracts, the valve opens. When the heart relaxes, it closes. And it's just reliant on a pressure gradient. The mitral valve is much, much more complex, where there is both an anterior and posterior leaflet, which are pulled open by papillary muscles, so little muscles which pull and open and close the valve. With that, that means that the muscles are attached to cords, which have to do all of that. And so we have to be wary of not entrapping ourselves in any of that subvalvular apparatus. And so at the moment, the pathway to mitral valve minimalist treatment is twofold. One is what we call a fully percutaneous mitral valve replacement, as shown here on the left. And the second is what we call a mitral clip, where we put essentially a bulldog clip in the middle of the leaky valve to bring it together and reduce the degree of leak. So this is our timeline here in Brighton. Sorry, let me just, for some reason. Here we go. Our mitral technology has taken a lot longer to come to market, and we started in 2007-10. At that point, Professor Dave Hildick-Smith, that some of you will know about, and Uday Trivedi, who were one of our lead surgeons, were pioneering all of this, helped by a very young and good-looking fellow, which was myself at that particular time. Then there was a hiatus around 2011 where there was no funding for any of this. And then there was this gap till around about 2017 where we did our first cases of fully percutaneous mitral valve replacement. We did 3 as part of a clinical trial. And then again, there was a second hiatus where there was no funding again for any of this. The UK was then commissioned to undertake mitral valve replacement by the keyhole technique in 2019 in 11 networks, which the idea being that, for example, we are a network between Brighton, Oxford and Southampton, and we would refer these patients between ourselves to optimally treat the patients. Some would specialise as valve replacement centres, others would do it as the clipping centres. Then came hiatus 3, which was COVID, obviously for 2 years. And it's just been that the number of UK networks has now increased further, and we are doing both combination of the clip and percutaneous mitral valve replacement in Brighton, the replacement being part of clinical trials. And we've now reached just over 100 of the clip procedures with very good outcomes. So what is the Achilles heel of percutaneous treatment? Well, at the moment, the only Achilles heel is durability. We don't have a long enough follow-up of our patients to be able to say 100% that your fully percutaneous transcatheter aortic valve replacement is going to last you 15, 20 years like a surgical valve, just because we don't have that length of follow-up yet. We are getting there. There is 10-year data for TAVI, and there's 10-year data for mitral valve clipping, but there isn't any 10-year follow-up of data, for example, for a fully percutaneous mitral valve replacement. So at the moment, as it stands, surgery may remain the gold standard treatment for certain mitral valve conditions, but certainly in the aortic space, TAVI is really starting to take off. So the future, where do I see it? Well, I'll be honest, I think smaller is always going to win, and smaller is always going to be better than bigger, and therefore there are going to be more keyhole procedures. We're going to do further ongoing trials versus the ongoing gold standard, which is surgery, and probably within the next 5 years, you'll be able to have a choice. For example, under the age of 70, maybe if born with heart problems, you'd want to consider surgery, but over the age of 70, there will be no need to open the chest any further, and less, in my opinion, is always more. Thank you very much.
Thank you very much, James, for that. I think your last slide may have frozen a little bit, but we will, as I said earlier on, make sure these slides are put on our website so people can watch back in terms of those. Does anybody have any questions or any comments for James? I mean, certainly from my point of view, your timeline seemed as you said, very recent in terms of this. I mean, you talked around CT scans coming in when I was just a little lad, and then the work that's been done in the last few years rapidly around the options that we have available now in terms of the replacement. So phenomenal amount of work gone in, and I know that you're quite rightly proud of the research that we're doing as a trust in terms of in terms of supporting that national trial and the work that we're doing as well. But does anybody have any questions for James? As I said at the start, we can't take any personal questions because it's an open forum, but if you have any more general questions, that will be great. I can see that Alex has got a hand up and then Peter Rose. So if we take Alex first, you will have been on mute, Alex, so you'll need to unmute yourself to ask the question, and then we'll go to Peter. So did you want to go first, Alex? If you're able to unmute yourself. Okay, well, what we'll do is we'll come back to yourself. Peter, are you able to unmute yourself, and then do you want to ask your question first?
I hope I'm unmuted
You
now.
are, Peter. Thank you very much.
I must say thank you very much for what I found was an absolutely fascinating stage. My question is really simple. Given how much things have moved forward over the last, well, certainly 40 years, coming down to 30 and 20, where do you see things going in the next 10, shall we say?
It's a good question, Peter. I think there will be a predominant move to trying to avoid as many open procedures as possible across all areas of medicine. If you can avoid an operation at all cost, one, the patient's going to feel better, they're going to heal better, there's a lower infection risk at the same time, and with that, the length of stay in hospital is going to be shorter, which is going to keep the health economists happy at the same time. So I think there will be more and more move to doing things in a more minimalistic way as much as possible.
Yeah, and I think we all like to, whilst we work in the NHS and so on, we don't really want to be spending too much time in the hospital if we don't need to. So I think you're right, James, in terms of allowing people to get home, they recover better, in terms of those environments as well. Thank you very much, Peter. I see, Alex, you put your hand back down. Is that because you weren't able to unmute yourself? I can see that a couple of people have put some thanks in the chat. So we have a Sylvie dialing in, I think from Montreal, saying a great set of research. Please continue that going. In terms of that, one of our local consultants, Alamiri, saying thanks so much for presenting on this topic. And Frank has also said, gripping presentation. I think that was because of your great choice of animations that you'd put in there as well. I can see there's a couple of hands gone back up. So so Marie, if you're able to unmute yourself, we'll take you first, and then Anne.
Thank you, James. Now you're doing this sort of procedures in Brighton. I had an ablation in Southampton. Does that mean that then patients will have a choice as to whether they use Southampton or Brighton, or are they dedicated procedures at dedicated centres?
It's a very good question. I mean, patient choice theoretically should work, that if you wish to go to any specific centre, you can ask specifically to go to that centre. People, with regard to structural heart disease, then actually we offer everything in Brighton that you would get otherwise in London or anywhere like that. And most of the time, people don't wish to travel that far unless they need to. But the idea of a network is exactly that we may refer people between different centres because different centres have different expertises, essentially. But that's just during clinical trial periods. If that all becomes standard of care, then most units will probably be able to offer all treatment options going forward in the next 10 years or so.
That's good. Thank you very much. It's a brilliant presentation. Thank you.
Thank you.
Thank you, Marie. So Anne, next. I think you've unmuted yourself, so take your question.
Yeah, hi. It was just your diagram where you showed the rotational atherectomy with the calcium removal. I was just wondering, what happens to the calcium running through freely in the artery, or do you have a method of sucking it?
It's a brilliant question. I'm very impressed. Essentially, the diamond tip on it rotates at about 60,000 RPMs. And so it pulverizes the calcium into such a small particle that it's just absorbed by the body and got rid of that way. It's an absolutely brilliant question. I'm very impressed. And literally,
I had a vision of these lumps of calcium traveling through the arteries, thinking, well, that's not great.
Yeah, unlike the TAVI stuff where you are breaking huge bits of calcium, which can theoretically travel north to the brain and block an artery. In this particular case, it's pulverized so small that it's picked up by the reticular endothelial system, which is essentially the blood's waste center, which gets rid of it, and it's all got rid of that way. But it's a very good question. I'm very impressed.
Very clever. Okay, thank you very much.
Okay, thank you, Anne, for for that question, and a very knowledgeable bit, putting James on the spot there in terms of the clinical diagnosis that you were talking about there. But really pleased to hear that in the design of those apparatus, they've thought through. Actually, it's not just about breaking up and leaving it in big lumps. It's about making sure that it can be sustainable, and if it's absorbed back in to the body, then that's not causing those sorts of problems that James was talking about in terms of the nets and the trial that's going on at the moment. I can see Maria has got a her hand up if you want to ask your question. Hello, Maria.
Thank you very much. Like the others, I've very much enjoyed the presentation, and as in sort of old cardiac nurse from the late 70s and 80s, I certainly have seen quite a lot of progress. Now, my question is, how much does it cost to, I remember the days of cabbages where patients stayed for 10 days in hospital. Now,
Sure.
if you're talking about one day,
Mm.
but of course we've got the sophisticated equipment, how does the cost compare for the old traditional methods of, doing coronary artery bypass grafts, for instance, as compared with angioplasty now?
It's a really good question again. So the answer is that the health economists look at something called QALYs, or quantity of life years gained from a procedure, and the cost of the procedure overall in terms of length of stay. So as long as the patient is going to benefit from the procedures in terms of life years gained and the length of stay is short, often then they will invest in those areas, for example. Now, coronary artery bypass grafting, which, as you say, or cabbage, was a brilliant treatment, revolutionized things in the 70s, but it was the longer length of stay at that particular point that was its Achilles heel, because actually the cost has remained pretty neutral. It's around about £24,000 for the procedure, but then 10 days of 700, well, maybe £1,000 a night for the first 5, because you're often on level 2 HDU or something like that, and then 7 days, as you say, of a standard hospital bed sort of doubles that to about £50,000. Let's make it easy for everyone, or something like that. Whereas a stent used to be very expensive. They used to be about £3,000 per stent, but actually because of competition and other device companies coming to market, then a stent is roughly around about £300 now, and the cost of the person coming into hospital, because they don't stay in the hospital, they just come in as a day case, is actually very cheap. So we can do maybe between 6 and 10 procedures per day of keyhole treatment, whereas the surgeons do maybe only 2 operations per day. So, but for example, the aortic valve replacement probably costs about 25,000 when you were doing it, whereas the TAVI valve now alone is roughly around about 18 to 20,000 pounds. But again, the keyhole nature of it, meaning that they're only in hospital for 1 day, is where it becomes cost effective again overall relative to the surgery. So again, it's all about the combination of the two balancing out in that regard. So in certain procedures, it's a higher upfront cost, but shorter length of stay. In some of it, it's pretty much the same costs, but long lengths of stay, which are their Achilles heel.
Yeah, and I think that's a good point to you, James, isn't it? In terms of it's the overall cost, the long-term cost of the procedures that we're looking at, and that's balanced against the quality of life that you gain. So a shorter length of stay, less invasive procedure is always going to give you some benefits to offset that initial cost, as we're miniaturizing the procedures and the technology that we're using. More and more people getting involved in that market brings a degree of competition to that, which again drives down the cost in the longer term. But you have to build up that groundswell of usage to demonstrate the benefit of those procedures. So the NHS are not in these things for a short-term gain. They're in here for the much more to the longer term. So that's why they look at the quality of life overall cost that we're looking for. And as James has reminded us all, we're all living much longer as well. So that quality of life is about extending that period as well. So my granddad, great granddad, wouldn't have made it past a year 40 working in heavy industry. That's now moved on, and people are making it to 60, 70, 80. And I'm really pleased, James, that you were saying 70 is the new 60 and 60 must be the new 50. So I must be getting younger as we're going through this presentation. So
it really is.
I'm really pleased with that. I'm going to hang on to that. So I'm just wondering whether anybody's got any final questions before we let James go for the night. And just want to wish you again, James, great thank you for from all of us on the call. We will save the presentation on the website. We have been recording this. We'll just check that the sound quality is good, and then people can also watch that back as well. So thank you very much, James, for giving up your evening for such an enjoyable and an interesting talk. can't see anybody else indicating that there are any more questions. And there are lots of people using technology better than I am in terms of being able to indicate a virtual thank you with their emojis. So thank you very much for all of that, and look forward to seeing you at our next expert talk in a few months' time.
Pleasure. Thank you ever so much.
Thank you all.
Thank you.